Hello, this is Ms. James, and I'm going to attempt again to record your lecture for Chapter 22, just in case there are some things that you need to reinforce what you've already been reading. I apologize, the other one does not work, but the day that I recorded, it was multiple interruptions. So let's get started. This is the postpartum complications and adaptations for mothers who are at risk after the delivery of their baby. And we'll also talk some about postpartum depression and a few of the other things out of chapter 22 that I felt were very important for you. As we all know and what you've seen, it takes a lot of teamwork whenever we're working with postpartum moms. You're not alone, especially in the labor and delivery environment. You can look at this little cute video if you like. And during the puerperium, there are physiological changes, especially with the reproductive system. And you guys always have heard us say it, and it's getting rather redundant at this time. During this period, the uterus undergoes the involution process, and the way we can determine this is by assessment of the fundus. Where is it located? And if she's experiencing any type of uterine issues, it's usually first noted by assessment of the fundus. And this is out of another book, but you have a picture just like it in your book on where the fundus should be by day 1, day 2, etc. And if it's different than midline, we should be documenting this, and we should be figuring out what the problem is. These are just some other examples of how full bladder can displace the fundus away from the midline. Who will have a slower involution? Someone who is multiparous, a woman with an overdistended uterus. She may have some type of an infection. There has been a retention of the placental tissue. Or who would be faster? We've talked about this in class. Who would have the faster involution? Naturally, moms with who are primips, moms who are breastfeeding, and moms who have had pretty much an uneventful pregnancy and everything is working just the way as it should be. But those also who have oxytocin. After pains, who has more? Multips, those who have an overdistended uterus, and also breastfeeding mothers because of the oxytocin. So our focus is pain relief, of course, positioning of comfort, and a lot of reassurance, because as we know, those of us who have been in OB clinicals, mom is not going to be 100% pain-free no matter what we give her. You have this chart in your appendix as well, what the lochia should look like. And it's very important when you're documenting that you use these terms instead of her blood is red, it's dark. We call it rubra, serosa, and alba. And the amount scant, light, moderate, and heavy. She is a fall risk during the intrapartum period. Why do you think? Her gait is off, her balance is off. She's having different types of medications that we may have given her that makes her a fall risk. During the postpartum period, she's taking pain medications. She's getting accustomed to a new fluid volume shift. So we have to be very careful, because if she's been lying in bed all day, or the epidural has just been discontinued, and her first time up, she'll be wobbly and she may fall, or she'll have a change in blood pressure and she may fall. So we have to remind our moms of these things and remind them to get someone to help them if they need to get up. Neurologically, she's sleep deprived. She may have a headache after the epidural, and those include she may have to come back in and get a blood patch. Um, she needs to be screened for any type of blood pressure exacerbations, proteinuria, blurred vision, light sensitivity, and there are differences in preeclampsia and eclampsia. So those things you need to look up in your book, and we talked about some of those last week. Contraception concerns, if she's breastfeeding, we talked about these things too. Usually menses will be a little bit later to return, so she needs to talk to her physician about means of contraception. The frequency and the duration of breastfeeding does have a huge impact on when her menses will start again, and usually she needs to start using contraception methods by the time the baby is at least 6 months old. But often you need to start talking to your physician earlier, because there are some moms that are pregnant again 9 months later after the baby is born. Bottle feeding menses should start by 9 weeks. And still, at that first visit, start talking to the physician about safe contraception methods. The breast, we talked about these many, many times. They need to be observed. If she's got any type of dimples, sometimes that's indicative of a tumor. But remind mom, they do feel a little lumpy and bumpy because milk production causes those milk ducts to get full. Just because she's got small breasts doesn't mean that she's got a small amount of milk. If the nipples are flat, though, it's harder for to breastfeed, and so we may have to give her some nipple shields to help that out. Sitz baths, we use those many times if she's had a difficult vaginal delivery, has some swelling or some laceration, or even an episiotomy. These can be done once a day, but you need to remember it's cool water for the first 24 hours to help decrease the edema, and then warm water on the second day to help increase circulation and enhance the healing process. And so it's very important to explain those things to her. You don't want to do warm water within the first 24. That's just going to make the edema worse. And of course, ice packs are good. Always remember, if she's using the sitz bath in the hospital, that very well before she gets in. C-section teaching, no heavy lifting. The incision should not be submerged in a tub. Taking showers are good. The incision needs to be kept clean and dry. She needs to observe really good hand washing whenever having her hands around that incision. No driving while taking narcotics, and she needs to know when to call the physician, because if she starts having any drainage for that incision, starts having fever over 100.4 with chills, or anything that's unwarranted or things that she has question about, she needs to call, because it's been major surgery. She needs to be careful. Bottle feeding, we've talked about this in class. Snug bra, sports bra is best to wear 24/7. Ice packs, no warm water showers during this first 72 hours, because that milk is going to come down and it's going to be painful. No pumping or massaging of the breasts, and without any stimulation and without any warmth and without the baby sucking at the breast, they should return to normal within 72 hours. We've talked about pelvic rest and sexual activity. It's very important that we document the teaching that we've given and allow them to ask us questions so that we can teach their significant others or their caregivers about the importance of waiting, especially if she's had a laceration or trauma to the area after a vaginal delivery. Psychosocially, bonding is very important. We've talked a lot about this in class. It's a very important process for the parent and the infant during the first few days, and we want to definitely make sure that we support that as much as possible, even if it's very brief. It's very important. Attachment is a two-way bond between the mom and the baby and the either the significant other as well. It's very important between the parents, their children, and especially the siblings for them to adapt to the changes. In face position is mom looking right into the baby's eyes. It's a mutual gaze between the both of them, where mom is touching the fingers, the toes, touching the infant's body, making sure everything is just where it should be. And she holds the infant. That's called enfolding, and this is called binding in. And this is a very important process to go through. Rubin's levels of adaptation taking in is where mom is focusing on the need for fluid, food, and sleep. And others are usually helping her make the decisions because she's reliving the birthing experience, and she's kind of self-centered right now at this time because she's needing to get herself back into reality of now, okay, I'm a mom, so I've got to start taking care of myself and then take care of the baby. And then during the taking hold phase is when she becomes more independent, and she's concerned about caring for the newborn, caring for her bodily functions, and sometimes she may be a little bit anxious, and this may extend over several days. The taking hold phase is when she's very teachable, and she's listening to what you're having to say if she's a new mom, and a time to help her find her some referrals if she's needing extra services. Then letting go phase is where she's letting go of what she used to do before she became a mom, letting go of that ideal birth experience if she had some type of birthing plan and it didn't go the way she had planned, or ended up with a C-section when she really hoped to deliver vaginally. And if there's some little small imperfections, a finger that doesn't look quite right, or a foot that doesn't look quite right, or the hair is just standing all over the head, she's letting go of those fantasies of having the perfect little infant. She is accepting this baby for just how beautiful it is. During the taking in phase, it's very important that we help meet her physical needs, allow her to rest, make sure she's eating well, and let her talk about her feelings and determine if she's going to need some support. During the taking hold phase, we're starting to support her role as the mother, giving her opportunities to take care of the baby herself and support that role in case she needs any further teaching. During the letting go phase, here again, she needs to be allowed to express any types of feelings she may have, because we want to make sure that if she's not adjusting well, that we provide her with opportunities for outside services or outside support after she goes home. For the father, his adjustment is called engrossment. He's absorbed and preoccupied with this infant, and he's very interested in this new infant. And so it's very important for us not to forget about the father, because he is going to play a key role and is very important. Even if mom and dad aren't married, it's very important to be supportive of this role so that the child is well bonded between both parents. All right, I'm going to move on into perinatal mood disorders, postpartum depression, because it's a very important thing to take note of. It does occur, and the main important thing to remember is to understand whenever it's just the postpartum depression that occurs because of the hormonal changes and getting used to this new role, whenever it turns into something more than depression, and it's something that could be an unsafe environment for both mom and baby. There's depression, anxiety, and then it may roll over into an OCD, an obsessive compulsive disorder, or PTSD, post traumatic stress disorder, or sometimes even a psychosis, or into a bipolar condition that we have to make sure we're understanding if something is happening, and if she has a history of postpartum depression, make sure she has some help. Um, there has been a marked increase in this disorders during pregnancy and the postpartum period. Not really sure why, or if it's because we are more um, adept to recognizing these problems, or if it's because moms are a little older now, uh, and we are so engaged in our work ethic, and we're having a baby and it's interrupting how we're used to interacting socially. Not quite sure. But the incidence of mood disorders during pregnancy is 7 to 22%. What we're talking about with the baby blues, which is like postpartum depression, that's usually expected in the first couple of weeks after delivery, is about 80%. And these are coming from a different source, not out of your book. Postpartum depression and anxiety occurs in 10 to 20% of the moms, and psychosis occurs in 1 or 2 in every 1,000 births, which that's a little bit on the scary side when these are the moms that are found to be driving their children off into the water, or drowning them at home, or other thing, or suffocating them. And those are the ones that you want to make sure you recognize some help before something terrible happens. Postpartum blues is a transient period of depression. She may cry, she may be very irritable, angry, uh, not sleeping well, very exhausted, tense, unable to concentrate. And these moods go up and down the spectrum, and they're short lived, they don't continue. These are due to rapid hormonal changes. She has the physical and emotional stress of the labor that she's coming off of. She's uncomfortable. When you're pregnant, you're feeling the baby move, and that is a most wonderful interaction between the mom and the baby. And after birth, you're not feeling that anymore, and that was part of the excitement. So that's kind of a letdown. Um, she's got an increased sense of responsibility. She's not getting enough sleep, and of course, she's got to come back to reality now. The life was stressful before. You still got to go back into that life after, and you still got to pay bills. You still got to do the regular day-to-day things that you were doing before. She might feel overwhelmed. She might feel guilty, ashamed, depending on what the situations were surrounded by the birth. She might not be eating enough or eating nutritiously, very fatigued. Sometimes she will reach out for help, but sometimes she won't. Um, she may be a little on the suicidal side. This is whenever it gets really scary here. She's getting more away from just the postpartum depression, the baby blues, into more of a deep, deep depression. She may feel hopeless, and whenever they're starting to feel hopeless or guilty, um, then this is whenever we need to intervene. She has loss of interest or pleasure, and she may end up becoming more and more anxious. So, whenever this part occurs, this is whenever we really need to pay attention that she is becoming more depressed. Now, if she begins to start going into more of a delirium or psychosis, like some days she feels like driving off into the river, then she's getting more into the psychosis. And that is whenever she needs strong professional help. During the depressive stage, or if she's moving into more of a psychosis, she is needing more than what we can give her. And even the family needs to be in tune to what's happening Not leave her at home alone with the baby because it won't be safe. I'm going to move into postpartum hemorrhage a little bit. You guys have a lot on this already. Um, and we talked a lot about it in class. The main thing you need to know is that it is life threatening. It can cause maternal death. Um, we need to remember that estimated blood loss is just that, it's an estimate. So weighing of the pads, as you saw in your textbook or on the video that we saw, that is the most accurate. In reality, we're going to be looking at the pads and tell how many she soaked within an hour. It can be caused from uterine atony is the most common. Others are lacerations, if she had an episiotomy, if there were retained elements of the placenta, a uterine inversion coagulation problems, if she had a large for gestational age baby, or a failure to progress. There are just multiple causes. Tone, tissue, trauma, thrombin, and traction. We talked about that placental traction. Someone saw this occurring in the labor room yesterday, actually. That can cause a potential uterine inversion. 22.2 gives you an overview. We have to assess her for risk factors. Look at how much bleeding she's having. Most deaths will result from an untreated, slow, steady blood loss. She also needs to be assessed for hematoma. There, you may not be able to see one. She may have one on the inside. And so, what are the first steps we need to do for excessive bleeding? Massage. Empty the bladder, massage. And if it's still boggy, we need to call. Or if we're massaging and we're concerned, we get our partner, our team member to call so that she's not decompensating. Fundal massage, 22.1, IV fluids, oxytocin. If those fail, then the physician will have to do a bimanual compression or an internal packing, or even a balloon tamponade, which looks like a large Foley catheter. To express clots, the fundus has to be firm. If the fundus isn't firm, then we may need to, if you keep on massaging to express the clots, and this was where it gets very confusing a little bit. If the fundus is not firm and you continue massaging, you can increase the uterine atony, and that can cause the uterus to invert. So if what we do is not helping and what the physician does is not helping, he's going to need to take her to surgery, because the clots are not going to express if the uterus is not firm. You just think about something real boggy and squishy, and it's not contracting and firm, because the uterus has to be contracting to deliver the baby, if you think about it that way. So if the uterus is boggy and squishy, it's not going to expel clots that are developing on the inside. And if she continues to bleed and not express the clots, then we're going to have a big issue. That's why it's the internal compression or the packing may have to be done. She's going to have 2 IV lines, one for IV fluids, the other will probably be for blood transfusions if she needs it. Her vital signs every 15 to 30 minutes. We'll be checking her level of consciousness. Possible plan for a D&C, and we're going to continue to assess her for shock. She can go into DIC, just like what I talked to y'all about last week, but you're not going to need to know all those particulars. Predisposing an overdistension of the uterus, a multip, a large baby, hydramnios, multiparity. It depends on the woman. It could be greater than 5 babies or it could be less. It just depends on the woman. If she's had to have the use of tocolytic drugs, if she had a precipitate labor or delivery. Precipitate means very fast. A prolonged labor, or if forceps were used or a vacuum, or if she had a cesarean birth. So you can see just a manual removal of the placenta, a previous postpartum hemorrhage, if she had to be put under general anesthesia, if the placenta was implanted low, if we gave her mag sulfate, if she has a clotting disorder, or if she had some type of previous uterine surgery, which there again, a C-section, or a classical incision, or adhesions, just about anything is why we need to really be. Labs, like we talked about, fibrinogen, prothrombin, PTT, platelets, sometimes a D-dimer. Management for uterine atony. Massage the fundus, express the clots, remembering that the fundus needs to be firm to be able to express the clots. Pharmacologically, infusion of Pitocin. She may also be given Methergin or Hemabate or Cytotec. She will probably, if she has hemorrhaged, need blood replacement. And sometimes, if it's really bad, she will have to undergo a hysterectomy. Remember, an IV is always going to need to be lactated ringers or normal saline. This is just a picture of the bimanual compression of the uterus to try to firm it up. And we've already talked about vaginal packing. He may have to take her to surgery, and definitely will be type and cross matching and doing clotting studies. What should we suspect when the fundus is firm midline at the umbilicus and the bleeding is still bright red? What are we thinking? Well, probably not sepsis. But if it's firm, midline, and at umbilicus, more than likely she may have some birth canal trauma. Number 4. Trauma. Lacerations to the cervix, vagina, or perineal area, a hematoma, or some type of trauma from using a vacuum or forceps. It's the second most common cause of early postpartum bleeding. Deep, severe pelvic rectal pain. Remember, you may have concealed bleeding and the formation of a hematoma, and sometimes it may not be visible. Sometimes sutures are needed for the therapeutic management. Late hemorrhage may be caused from a subinvolution, a retained placenta, or an infection. It's very important that we teach mom because she may go home and this may happen. The physician will usually need to do some type of manual exploration, a D&C, sometimes antibiotics, sometimes some more oxytocin or Methergin. Sometimes this can occur without warning 6 days to 6 weeks after delivery. That's why it's very important that we teach her well. Tachycardia is what of hypovolemic shock. It's an early symptom of hypovolemic shock because it's the body's sign to us that is trying to compensate. And she may have already lost 25% of their blood volume by the time the tachycardia appears. Thromboembolic disorders. It's very important to assess for these, especially for DVT. It usually happens with the saphenous veins in the lower legs. DVTs are usually from the foot to the iliofemoral region, and both are a heavy cause of pulmonary emboli. So this is why we have to assess, and we have to instruct mom, especially if she has varicosities. Collection of platelets and fibrin on a vessel wall is what is associated with thrombophlebitis, which is an inflammation of the vessel wall. Major causes of thrombosis: venous stasis, which we've talked about, endothelial layer injury to the blood vessel are the major causes, and we have to be very cognizant of that. DVT, deep vein thrombosis, swelling of the leg 2 centimeters greater than the opposite leg, erythema, heat, tenderness, pedal edema. We don't check for the Homan sign, but we can look to see if there's redness along the course of the vein or heat, or she complains of pain, if the lower extremities are pale or cool to touch, if it's painful to walk, if she's got chills and just malaise. She'll need an ultrasound, an MRI, or a venography. Sometimes they will do a D-dimer, but nowadays you've got to have reasons for doing D-dimers so that they'll be paid for. And it's used as a screening tool for high-risk patients. And if it's positive, then they'll do a venous ultrasound. Treatment: bed rest, affected leg needs to be elevated, gradual ambulation when the signs and symptoms are disappeared, anticoagulant therapy. Analgesics, she'll probably be placed on antibiotics. She'll need continuous moist heat, and of course labs will need to be drawn to make sure the anticoagulants are working. PTT should be kept at 1.5 to 2.5, but now we also watch the INR ratio to make sure it's within normal limits. Postpartum, Coumadin and heparin will be overlapped. Coumadin will be given for up to 6 months, and it is safe with breastfeeding, and it's very important to teach with Coumadin. Y'all should already know what Coumadin is and what's important about eating and how it's taken. Pregnancy, she can take it after meals for 4 months, and then after meals for 6 weeks after therapy, and this is heparin. During pregnancy, no Coumadin. So it's very important to know those things. She can't wear any constricting clothing, no prolonged sitting, report hematuria, bleeding gums, bruising, a bloody nose, increased vaginal bleeding, no walking barefooted, use a soft toothbrush, use an electric razor. Over-the-counter herbs and some over-the-counter meds can cause increased bleeding and might interfere with absorption. Vitamin K foods, remember the risk of those. And while she's on Coumadin, she must use effective contraception, because while pregnant, she cannot have Coumadin. Okay. Now, I believe what you'll see is Lovenox, and she'll be taking Lovenox sub-Q during pregnancy. Protamine sulfate is the antidote for which one of these drugs? Very important that you know that. And what's the antidote for Coumadin? Of course, it's vitamin K. Pulmonary embolism, what is the signs and symptoms? The signs and symptoms are very dependent on how impeded the blood flow is. The most common is dyspnea, and if she has sudden sharp chest pain, and then if she has tachycardia or tachypnea. The others are getting a little late. If she's having syncope, a sense of impending doom, her chest starts sounding wet, she starts having cyanosis, spitting up blood, and then if she starts having unequal breath sounds, it's getting worse. Treatment, of course, she needs ABGs. We want to do measures to dissolve the clot. TPA or streptokinase, oxygen, analgesics, bed rest, head bed elevated. She will be going to ICU. If there's no time, an embolectomy may be done or should be put on a heparin drip. And that's the last resort, unfortunately. Doing an embolectomy is very high risk. Infection, when the temperature is over 100.4 degrees. And this is after the first 24 hours following childbirth. Usually, if there's an infection, it'll occur at least 2 days during the first 10 days postpartum, and it's usually bacterial. Sometimes the little small lacerations that we can't see will create portals for infections because all of us realize she goes home, sometimes she's going to be on a laxative because she really needs to have ease of having bowel movements, and that's a perfect site for an infection. Risk, normal pregnancy is an alkaline environment, and so they're more at risk for having an infection afterwards. Cesarean birth is the main cause for an infection. If she's hemorrhagic or anemic, a trauma, prolonged rupture of membranes, which you all know, a prolonged labor, if she's had a catheter, or excessive vaginal exam, fetal scalp electrode, or intrauterine pressure catheter is also a risk. Retained placental fragments, poor general health, poor hygiene, poor nutrition, diabetes, of course, low socioeconomic status, more so than not being able to afford health care, more around the lines of unable to get the appropriate access to care, which you already know is one of my pet peeves. Signs and symptoms, of course, fever and chill, pain, redness, drainage, tachycardic, the uterus is not involuting the appropriate way, abnormal duration of lochia, it's got a foul odor, elevated WBCs, frequent urination, difficulty urinating, urinating blood, suprapubic pain, areas of warmth, redness, or tenderness, especially in the breast if she's running the risk of mastitis, body aches, general malaise. All this, table 22.3 in your book, page 783, will help you review those. Potential sites. Here's a little picture. Pretty much just about anywhere. Specific infections, endometriosis, endometriitis caused by a strep or E. coli. She'll need broad spectrum antibiotics. A wound infection is usually from staph. Broad spectrum is good for those. Urinary tract infection, which we've already talked about. She's having bowel movements and everything after a vaginal delivery. Most common is E. coli. Mastitis caused from a Staph aureus. That's when the breast will get really hot, red, painful, and she's running fever, antibiotic therapy, and she's got to continue to empty the breast. Sometimes physician may not want her to breastfeed because there's potential infection, but he'll have her to express the milk and get rid of it to keep them empty. Mastitis can occur at any time after delivery. It's very important for mom to have a correct latch, not to skip feedings or stop breastfeeding abruptly because this will cause her breast to fill because it's expecting to feed the baby, and then she doesn't empty and an infection may occur. No tight bras because the ducts will not empty appropriately. If she does have mastitis, moist heat or ice, naturally best for her to be on bed rest, and she has to continue to pump or breastfeed to prevent an abscess from occurring. If she does develop an abscess, she won't be breastfeeding, and there's just a whole another treatment regimen for that. How can we help the mom who is breastfeeding and has engorged breasts? What would we do? Instruct and assist the mom to massage her breast. Um, Sometimes the baby just does not empty the breast well, or mom keeps the baby on one side longer than the other and she's going to get engorged. That breast needs to empty, even if she pumps it and saves it, freezes the milk to prevent her from getting mastitis. Massaging the breast releases oxytocin and increases the speed of the milk release. Engorgement is more likely to increase if breastfeeding is delayed or infrequent. The bra that's really a good fitting bra should be worn day and night to support the breast. Cold used in between feedings to reduce edema and pain. Heat just before the feedings helps with the vasodilation and the letdown reflex. Okay, she delivered a 9-pound, 10-ounce baby an hour ago. You give her a 15-minute assessment and she tells you she feels wet all underneath. Both pads are completely saturated. She's lying in a 6-inch diameter puddle of blood. Our first action is, okay, she delivered an hour ago, and we do a focused assessment, and she feels wet. We see all the saturation underneath her. Yes, you're going to call for help. Yes, you're going to take her blood pressure. Yes, you may need to check for lacerations, but what is the very first thing you need to do to see what you're looking at? See what your situation is so you will know what to do next. The very first thing is you're going to assess the fundus for firmness because you're going to call, but what are you going to tell him? The first thing the physician is going to ask you is, what does her fundus feel like? And the very first thing you're going to do is assess for firmness, and you'll do the other things as warranted. Firmness is necessary to control the bleeding, and so you have to assess for firmness and massage. And that after that, then you're going to get someone to take your vital signs for you. You're going to look for any lacerations that you can see, and you are going to call the provider. Real quick. She's got a 36 BMI and she delivered a 9-pound boy. And she's how old? 40. She's been pregnant 6 times. She's delivered 5 times. So here again, what are her risk factors? She's a multip. She's obese, had an LGA. She's got a slight temperature elevation. She's possible choreo because those membranes were ruptured. And she's got a history of prolonged rupture of membranes. Okay? So overdistension by LGA with a rapid involution is necessary to prevent a postpartum hemorrhage. And it makes it more difficult because the baby was large. Repeated stretching reduces the efficiency of the muscles. Intrauterine infection increases effective uterine contraction during labor and postpartum. Obesity also increases the risk of hemorrhage. We've massaged and it's up above and to the right. It's not firm. She's got a large amount of bleeding and a saturated pad. What are we going to ask her? We're going to massage the fundus, of course. And what else? We're going to empty that bladder first, correct? Because the empty bladder, full bladder is going to cause the fundus not to be firm, and it's going to cause a displacement of the uterus. The most common reason for all this is uterine atony, and it may cause the uterus to be distended and deviated because of full bladder. Emptying of the bladder and massage could help the uterus to contract, and the hemorrhage may result in large blood loss over a very short period. So we're going to do these things, and if she still doesn't contract down, we're going to have to call the provider because we really need prompt treatment if she is bleeding out. What etiologies could also be? We've talked about these. There could be retained placenta, an unrecognized pelvic laceration, or a clotting disorder. Could be any of these things. All of these contribute to a postpartum hemorrhage. So the physician comes after we've emptied her bladder, we've massaged, and we still can't get anything to clamp down. We've called him. He comes, he evaluates, there's no laceration, and he orders her to get Hemabate IM. So why do we give that? To increase contractions and decrease bleeding. It's used as an adjunct to treatment to IV oxytocin, in this case for uterine contractions. The common side effects of coerce that we talked about in class: nausea, vomiting, and diarrhea. And these occur in more than half the patients, so often we'll give them an antidiarrheal and an antiemetic at the same time. The ongoing assessment and education is needed, for sure, because hopefully the Hemabate worked. We're going to continue to take vital signs. We're going to continue to palpate her abdomen for the uterine tone. We're going to continue to position and check for tenderness and for bladder distension. That sentence isn't completed there. Continue to check for vaginal bleeding and pain. How would we know if voiding is adequate? We're going to assess her for dizziness, for any chest pain, for any shortness of breath, and of course, check the CBC for results. Instruction to request assistance. That means we tell her, do not get up by yourself. You need to be voiding at least every 2 to 3 hours, and I'm going to be coming in here to check to make sure that you're getting up to go into the bathroom, and I'm going to be here to be sure to help you to get up to go to the bathroom because you've lost a lot of blood, and we want to make sure that you don't fall. You will be dizzy. We're going to increase oral fluids, make sure she has plenty to drink. She's going to need to eat high iron foods because she's lost a lot. And we are encouraging her to breastfeed, and we all know those reasons why. Rationales for all this: she remains at a high risk for falling, a high risk for hemorrhaging again, and so we want her to stay at a high risk assessment. She must be monitored for increased temp because we've done a lot of different things that could cause her to develop an infection. Tachycardia may be related to blood loss, and it can also be related to an infection. If infection develops, she's going to need to start antibiotics. And she may even require some more redosing of the Hemabate or Cytotec or some more oxytocin. She's a fall risk. We are concerned about the infant's safety because she has had a lot of medications and she's very weak. We need to focus on if she's having any chest pain or shortness of breath because she could develop clots. We want to increase fluids and high iron foods because she lost a lot of blood and she probably has a hypovolemia and could develop an anemia. We know what oxytocin is for, and we know what Hemabate is for, and we know what breastfeeding will help. And she'll be in some pain because we've done some heavy duty massaging. If the physician has had to go in and do a bimanual, or if she's had to go and have surgery. So pain control is important. Why? So the uterus will contract back down as it needs to. Pain can impede a lot of things, and it can impede the healing process. Okay, this is it for chapter 22. Hopefully you'll be able to hear it this time. And I thank you all very much. Have a great day.